We are live streamed on Instagram and Facebook and YouTube, although no one ever appears on YouTube apart from family members and slightly stranger members of the community. So don't know why, but I'll take them. I mean, I'm not complaining. So got a Q&A going on. For those viewers on Facebook, of which there are none, I've moved my on air sign across for you, but maybe you'll watch it on the replay. So shall I get the thing off there? Got it off. I got it off. Yeah. Oh, I'm not going to mess with it anymore. So I've got some questions. If you've got a question, you can fire away and ask me here and now. If you haven't, then you can listen to the other questions that people have asked and see what you think. Question 1, do you offer 3D modeling for the predicted results? No, we don't. Oh, how do I get rid of that? Oh, God. So there's lots of ways you can do it this is talking about people. Oh, sorry. I'm trying to get rid of the. There's lots of ways you can work out how to choose an implant. And one way is by using 3D modeling, which involves taking a photograph and then morphing that photograph to give you an idea of what you're going to look like with different implants in. And it is an acceptable way of doing it. I don't do it, and anyway, there's lots of ways of doing something means there's no good way of doing it. So anyway, anytime there's lots of things, like there's lots of different types of implants, you've got to be careful when someone says this is the best implant, or if there's different ways of doing it and someone says this is the best way to choose an implant is by using 3D modeling, I'd be a bit wary of that, because I'm not even going to say the way I do it is the best way. I think it's the best way, or at least it's the way that works kind of for me, but I'm not saying it's the best way. I know there's lots of other ways of doing it and they're all acceptable. So that is what a plastic surgery is, a bit like that. It's a bit sort of surgeon's views and experience based, as opposed to scientifically based. There's no scientific way of saying the best way to choose implants. So anyway, I don't do 3D imaging. That's not to say I wouldn't, and we definitely have thought about it, and I'm not ruling it out. If I did do it, I would I think, I might be wrong because I don't do it, but I think it would probably be more of a marketing tool than actually a really helping me to decide what implants to have or what implants to talk to patients about, because I choose the implant for a patient based on 3 things in this order. 3 things, that's right, 3 things. The trident approach. Yeah, need a trident. The trademark, I need to trademark that, the trident approach. That's my thing. And in order of importance, number 1 thing is the width of your chest, the base width, because it's no good I don't know what this software, I don't know if the software will sort of only allow you to choose implants that will fit your frame, but the base width is the number 1 important thing, and that is set. That is something that I will measure when during the consultation. Then the shape and profile, shape being round and teardrop, profile being low, moderate, high, extra high profile. Once you've got the shape and the profile and the width, that's it. That's it, actually that's it. Pretty much the width and the shape and profile is it. Now, it's not as easy as it sounds in terms of shape and profile, because you can't just go and look at loads of shapes and profiles and decide which one you want, because you've got to add the shape and profile to your breast. So yes, different shapes and profiles give different kind of looks, but they also give different looks on different people. So a round implant might give a fake look to someone, but not a very fake look to someone else, based on what the shape of their breast is, because you've got to add the implant to their breast. But actually, once you've got an idea of what shape and profile you want and what width of implant you're going to have, you usually come down to like 1 or 2 implants in terms of volume. And then the last part, the trident, is the volume, which we use sizes in the clinic. So that's kind of how we do it in the clinic, and that works. But I completely understand that people do 3D modeling. They use these glasses. They used to do this thing with the like VR headset thing where you put on and you look down and look like what you look like with implants in. So there's all sorts of things you can do. I haven't written them off, but I don't do them. There's no guarantee you're going to look like what the 3D modeling person looks like, just like there's no guarantee you're going to look like what you look like with the sizes in, or what other people look like with moderate profile implants in, or whatever. But we're all trying to find the ideal way. And the moment I don't do the 3D modeling, I do it with with my Trident approach, and that works for me. But I can understand why it might be appealing, the 3D modeling thing, and people might think that's a good thing if they can see a photo of themselves morphed with the implants in. And I know people do it. I know good surgeons do it, so I know it's not a bad thing. Do you know what? I'm going to come to this later on, but the thing I would say to people that they don't spend enough time on is choosing the surgeon. I think they spend a disproportionate amount of time on choosing the implant. I'm not saying you don't need to spend time on choosing the implant. I'm just saying that people get so hung up on what implant they're going to have, and they often don't research the surgeon. And if you don't get it right, because I think I've got a question later on about someone who's not the pocket's not been made right. I saw that somewhere. I think, is it here? Yeah. So if the pocket's not made right, it's bad news. Doesn't matter whether you spend the rest of your life choosing the right implant. If the pocket isn't made properly, then it can be really bad and very hard to correct as well, very hard to come back from. And that you really need to spend time on making sure that you've got a good surgeon, as well as getting the right implant. But hopefully a good surgeon would guide you towards the right implant, and you wouldn't have to worry too much, just giving an idea of what sort of look you want. And a good surgeon will choose an implant that will fit your frame. But yeah, that's where I am with 3D modeling as of aujourd'hui. I might change my mind tomorrow and get a 3D modeling thing, and then try and look back at this video and hope and delete everything I've said. No, I don't need to delete it because I'm not bad mouthing it. I'm just saying I don't do it. Different strokes for different folks. What's Alison got? In general, after 360 FTL, I'll be 3 months post-op, 16th June. One side of downwards incision on lower tummy is not even and can pinch it and not flat. Is this normal at this time after op? Yeah, I mean, I normally say, Alison, 3 months is sort of when things start to settle. And always, Alison, talk to your surgeon is the best advice I can give you. Talk to your surgeon, work with your surgeon. But I think I might have said this to you before about the 360 fleur-de-lis. I'm not familiar with a 360 fleur. I think that's a fleur-de-lis. Is it FTL? Is that fleur-de-lis? FDL? I'm not familiar with a 360 fleur-de-lis. I wouldn't personally do a 360 fleur-de-lis, but either way, it sounds like a big op. A 360 anything is a big op, and sometimes there is a bit of laxity here and there. And yeah, talk to your surgeon. And I wouldn't kind of be thinking about doing revisions and stuff. You've got to leave things to settle. But it's, you need to see the surgeon in person, work with your surgeon. They know what they've done. They know what's happened. And yeah, I wouldn't kind of say it was normal for it to be able to pinch one side and not the other, and the incisions downwards on one side. That's not normal. But is it kind of like grossly abnormal? Well, no. Often with these things, there are incisions that aren't quite level or whatever, and things aren't symmetrical. So I would give it time is the answer to that. Give it time and talk to your surgeon. Ash is in the house with a blank one. Nice one, Ash. Thanks for the comment. It all adds all adds up. What we got? Thank you, Alison, and good luck. Stay strong. What brand of implants do we use for breast augmentation? Well, I don't use any particular brand, and I know a lot of surgeons, I would go so far as to say most plastic surgeons do kind of use a make. When you talk to your colleagues, they say, oh, I use this make, or I use that make. I don't. I use all the makes, all the types of implants. I do have a preferred make, stroke makes. But if you've got a preferred make, I can use any make you want, as long as the hospital can get it, as long as we can order it. I can use any implant that you want if you've got a view on it. because I use all the different types. I use smooth, micro-textured, macro-textured, and polyurethane foam implants. So I will use them all, and so they come in different makes. Generally speaking, I like Polytech, which is a German company which make polyurethane implants. Now they're the only company in the world that make polyurethane implants. So if you're going to use polyurethane implants, you have to use Polytech. I used to like the fact that Polytech made polyurethane micro, macro, and smooth implants. The problem is which really simplified life and made it a lot easier. But recently they've stopped with the rougher texture round implant. So they no longer make the rougher texture round implant. They only make a micro textured and a smooth and a polyurethane one. So therefore I have to go to a different make for different types of implants. So I tend to use Nagel for the macro textured implants. Smooth implants, I tend to use Motiva for the smooth implants. Sorry, micro textured. I mean, am I boring? Is this boring? Anyway, Motiva for the micro textured, and Motiva only make micro textured. Smooth, Nagel also makes smooth. Polytech makes smooth. There's a couple of companies that make smooth. So I use different makes depending on the texture of the surface, basically. But I haven't got a strong view, and there's lots of different. There's Sebin, there's Mentor, there's several different companies, and if you've got a view about it, as long as it's a big reputable company, I can use any of them. The only thing I would say is if you're using different ones, sometimes the numbers can be different, the dimensions can be slightly different. So it is good to use ones you're familiar with. I'm quite familiar with the certainly with the Nagel and the Polytech I've been using for many years. Motiva less so, and the Motiva booklet has got really small writing, so I have to put my glasses on to read that. But you know, that's something we can work with. I wouldn't make that decision not to go with Motiva just because the writing's small. So yeah, I use most of the makes personally. Julia, long time no see. I would like my skin to be taken off my back, bum lift, and bra line. Is this a difficult operation, or would you suggest lipo for contouring? I'm just wondering, as I only got one quote so far. Off my back, bum. Is there a comma there, Julia? I'd like the skin to be taken off my back. Is that comma? A bum lift, or I like to be the skin taken off my back with a bum lift and bra line. I always say, Julia, there's no such thing as a difficult operation. There's operations you know how to do and operations you don't know how to do. And taking skin off is generally not kind of a difficult operation. But I'll be honest with you, Julia, this sounds like an unusual operation because it's on your back and your bra line. It's unusual unless you've lost. Yeah, I was going to say we lost a lot of weight. Here we go. You preempted me. Weight loss, lots of skin. Yeah, I mean, when you lose lots of weight, Julia, there's common areas that people want contouring, and usually it's the front. Usually it's the tummy, it's the breast, it's the arms, it's the thighs. Those are the common areas, and then the back comes later. So you can take to tighten the skin on the back. That doesn't give a significant lift to the bum, and I think that's something personally. So it's an unusual operation rather than a difficult operation, and so I think you'll struggle to find someone who's got a lot of experience in it, and certainly I haven't got a lot of experience in doing surgery like this, tightening backs and bum lifts. Bum lifts are usually done by adding volume to the bum, because if you're just tightening the skin, and I understand when you've lost weight, you might feel that your skin is saggy. If you're just tightening skin, you're going to flatten the contour. So this is the thing with the bum. You kind of want a rounded contour. So tightening skin without adding volume is going to flatten the contour of the bum. And so that's something I'll be thinking about. So usually in terms of bum lifts, sort of inverted commas, that usually involves adding volume in some way, often with fat grafting and implants. So the two main ways of doing it has been a bit controversial. I think people are now thinking that it's okay to use fat grafting for injecting into the buttocks to give volume. I don't do it. There are some people who are. In this country, we've been a bit negative about it, but it seems to be people coming back to it now. Thank you, but I would like a shape to the bum, but don't want implants, etc. Yeah, well, if you don't want implants, Julia, then it would either be fat graft, or I would say it's Personally, I think it's difficult to get a shape. Now, people do talk about using your own tissue if you have got a lot of excess skin, and auto augmentation, sort of not injecting it, sort of folding it over and putting it inside your buttock to augment the buttock. Not something that I do. So I guess that would be a difficult operation. So yeah, so it is. Yeah, so I guess the answer is that is a difficult operation, what you're talking about there, because it's unusual, Julia, and it's all about, this job, I tell you now, is all about managing expectations, and it's about getting you on page with what can be achieved. So this is unusual. This is difficult because it's unusual. The other reason it's difficult is because operating on the bum, you'd have to be lying on your front. And personally, people are a bit different about this, but personally, I am a bit worried about operating on people when they're lying on the front. There is some risks with lying. We call it prone, when you're lying sort of face down as if on the beach. And so I don't like operating on people prone because there are more risks when they're lying on the front. In Eastis, it's a bit more difficult to manage the airway and what have you. So there's a few reasons why it is all a bit tricky. And yeah. And as I say, it's not common surgery because people doing stuff on the buttocks, certainly in the UK, is not massively common. Although there are, as I say, a few surgeons doing it. Omar Tillo, my friend in London, seems to be making a name for himself in the buttocks, in the in injections and what have you. So he might be someone to think of looking at, Julia. TILLO, not lovely guy, and he certainly seems to be embracing the fat grafting for the buttock augmentation. Would you suggest lipo for contouring? Yeah, lipo for contouring, but again, you've got to be a bit careful about liposuction and what it can be achieved, what it can do. Liposuction removes fat, so it doesn't actually necessarily tighten skin. So you've got to be careful what areas you use it on. There are assisted forms of liposuction that people say that tighten skin. Not sure how much it does tighten the skin, but anyway, that you have to talk to someone who does it, I guess. So, but yeah, so liposuction to a degree is good for contouring. There's certain areas where it works well. In my hands, I think the hips, the flanks, lateral chest wall, it works well. Male chest, it works well. Certain areas where it doesn't work well, in my view, on the abdomen. Is that a question I've got? Yes, it is. Got a question later on about that because it doesn't remove skin. So yes, liposuction is good for contouring, but in certain areas, and we often do it with kind of excisional procedures, and also volume adding procedures like implants in terms of breast and buttocks. But I understand if you don't want implants, that's perfectly understandable. Now, Pamela has given us a question on YouTube, so I feel bad now saying that we don't get anyone on YouTube, and now Pamela's on YouTube, so I'll take that back. Can I take the earlier comment about YouTube back? What is the best scar tape to use after tummy tuck? How often should you change the tape? So, first of all, Pamela, I would say talk to your surgeon, because I don't think I'm your surgeon. If I am your surgeon, talk to me. I don't recommend scar tape after tummy tuck. I recommend moisturizer massage. Now, some people do use tape, just micropore tape, paper tape, and they can use it for a few. I love micropore tape, and I use it in the early post-operative period. I don't use it for an extended period of time, but I know that some surgeons do use it for an extended period of time, for a few months over the incisions. They feel it does a good job. Yeah, I mean, that's just micropore paper tape. When you're saying scar tape, I'm wondering if you're talking about like silicone, which is more later on. So the scar tape is in the first few weeks after the surgery, the paper tape. People also talk about silicone, which comes as a tape, and that is more for hypertrophic red, sort of raised scarring. There's lots of different makes, and I don't know of any evidence to say one make's better than another. So I wouldn't recommend any particular make. There's loads of different ones, and I just go with whatever. Sil Gel, Care, Sil Derm, Keeler Coat. Anyway, there's loads. And they're all just silicone. I don't think there's any difference with the silicone. How often should you change it? You're supposed to wear it all day, so you're supposed to wear it 23 hours. So you just take it off when to wash and have a shower and things. So you're supposed to wear it all the time if you're going to use a tape. But as I say, personally, I advise people to massage and moisturize. So you can't use the tape and moisturizer massage because you just moisturize the tape off. So you do one or the other. And personally, I advise people to moisturize and massage the scar rather than tape. I think the tape is good for red raised hypertrophic scars. So so it is silicone tape you're talking about. Yeah, 3 months. Okay. It is good for red raised hypertrophic scars. But I don't think there's any good evidence for it for normal scars. So if your scar is maybe a little bit red but not raised, just a kind of normal scar, then personally I tell people to moisturize and massage. But I don't know if I don't think you're my patient, so I don't know if your surgeon has advised you to use silicone. Then I'd go with what your surgeon says. But as I say, if you're going to use silicone, you can't moisturize and massage because you'll just rub the tape off. So in terms of makes, Pamela, go for it. Whatever the cheapest is, or whichever looks best. I don't think there's any. Some of them come in sort of fancy shapes and things, but I don't think there's any evidence to say one makes better than another. So I can't really particularly recommend any particular make. I think we use Silderm. I think is the make we use, not an endorsement. Just I might even be wrong with that, but that's just what we use, just because that's Vicky. They got a nice thing with the silicone gel. It's got little ball bearings with pressure on it, so that's quite good. But I think they're all same kind of stuff. Thank you, Pamela. Thank you for what you got, Ash. Would you advise me to stay overnight after my breast augmentation because of my epilepsy, or do you think it'll be safe for me to go home if the op is earlier in the day? Ooh. I don't know. I mean, normally people go home absolutely fine, but I don't know. I take advice on the anaesthetist on that, Ash. If you can try and remind me, if you or you can drop me an email or something. I'll try and remember to ask Vicky tomorrow to ask the anaesthetist if they've got a view on it. I mean, normally people are fine to go home same day, but you would be more than welcome to stay overnight if you, if you would feel more comfortable with it. But we can kind of check with the anaesthetist that one. Ash, I don't know if I mean, the anaesthetist might want you to stay overnight. So that's a good question. And personally, from a surgical point of view, I'm happy for you to go home, put it like that. But it's more, like you say, for the epilepsy point of view, that they might want you to stay overnight. But personally, I'd be fine with you to go home as long as you're feeling okay. That's the other thing. I always say to people that plan to stay overnight, if you're not feeling well, you can always stay overnight. And so, bring a bag and things. But if come the evening and we've done it in the morning, come the evening you're feeling okay, I would have thought it'd be absolutely fine for you to head for the hills. Julia, thank you. Who is your friend in London? Omar Tillo, Julia. Omar Tillo. Have I posted that in the chat? Anyway, Omar Tillo is my friend. And he seems to be doing a lot of stuff with I should have replied to you anyway. So yeah. What's happened up Facebook? Anyway, okay. So yeah, that's my friend who does buttocks. Here we go. Why aren't you allowed chewing gum on the day of surgery? Now this came up a couple of, or let's say a few weeks ago, probably a few months ago now. Someone came to surgery chewing gum, and I think we've had to say there's World War III. World War III erupted. Hold on, what's happened here? Oh God, what's happened here? People, oh God, I've been neglecting. Use it. Oh God. World War III erupted because they walked in chewing gum. So that's where this has come. Webster's asked to join the video. I'm assuming you made a mistake with that, Webster. But if you haven't, I will accept your request and let you join the video. But so yeah, World War III erupted because the patient was chewing gum. I don't know, but just don't chew gum when you come to the surgery. I'm guessing you're kind of mixing the, because obviously you've got to be nil by mouth for 6 hours pre-op, maybe 2 hours for fluids, but certainly 6 hours for food, because they don't want stuff in your stomach, because they don't want you to aspirate I didn't. I thought it was I thought it was a mistake, Webster. So hi, Corinne. Corinne's here. So you know, obviously, I think the problem is if you're chewing gum, maybe you make more secretions in your stomach, and therefore you're more likely to aspirate. I'm guessing that was the problem with the gum chewing, but it was a bit of a it was a bit of a shock, I think, to the patient. That don't worry, Corinne, don't worry, it's okay. You haven't missed anything. I think it was a bit of a shock to the patient that they got told off that they were chewing gum. They kind of didn't expect to get told off, and I feel a bit bad because I don't think we explicitly say. I don't know if we do now. You know, don't chew. People don't tend to chew gum much anymore. You don't see it that often. It doesn't seem to be that popular a pastime anymore. But clearly, this patient was chewing gum and felt bad that everyone was saying that was really a bad thing to be doing. And I think the reason for it is because the increased secretions in your stomach, and the more stuff in your stomach, the more risk you have of aspirating when they do the anesthetic. So I think that was the issue. So don't chew gum on the day of the surgery. Nil by mouth means no food or gum. So actually, yeah, if you're stopping smoking and stuff, those are the people who chew gum, isn't it? Yeah, good point. Good point. Yeah. That. Chew gum. I've got a patient who's stopping smoking, and I just want to make sure she doesn't chew gum when she comes. So thank you, Ash. Message tomorrow. Yeah, try and message us. I'll try and remember. Thank you, Julia, for your question. Here we go. Is the consultation fee refundable or deducted if a surgery is booked? No. One word answer. No, it is not. What do I say about that? I think I used to do that ages ago. I think I used to do that refund. The reason people do that is because it's industry standard, isn't it? I think it's quite common in the industry for free consultations. I think a lot of the clinics do free consultations, and a lot of places only kind of charge a consultation fee to make sure people turn up. So they give you back the consultation fee if you have surgery. Now we don't. I guess the reasons are, first of all, well, actually, no, we do. Well, right, okay. So no, we don't. If you book for surgery, we don't. The reason being that, you know, you have a consultation and you have to pay for a lawyer and you have to pay for people's consultations. So yeah, we don't. We charge for the consultation, but we do have what we call our satisfaction guarantee, which means that if you're not happy with the consultation, if we feel that we can't help you, if you want something that we can't achieve, we will give you back the consultation. So we won't charge you if we haven't been helpful. So we do that. We do give you the consultation fee if we haven't been helpful, and we're not really the people for you. But if you go and have surgery, we don't refund it. I'll be honest with you. The other reason of it is logistical. It can be a bit of a thing, because if you're having a consultation and having a surgery relatively soon, I guess you might, no, that wouldn't work because you'd always pay for the consultation. I think that's right. When I used to work in the hospitals, people didn't pay for the consultation before, they paid for it after the consultation. So it was always a bit of a thing that if someone was having a surgery quite soon afterwards and we might say, oh, don't charge them for the consultation, because they've booked for surgery. And then when people were booking, we say, oh, have they paid for a consultation or not? If they haven't paid for is the surgery £5,000 or is it £4,800? We take the £200 off because have they paid or not? So it was a bit. So that was back. This is going back a bit a few years. So that's I think why I stopped. But that's probably about 10 years ago. Now we charge people pay for the consultation before, so you could argue that we could give them a refund of this consultation fee, but we don't. We don't know. Do I have to elaborate on that? I don't know if I have to elaborate on that, but I feel bad now. I feel like I'm on the spot, but we don't. We charge for consultations, but as I say, we have a satisfaction guarantee. Anyway, move on, Kemi. What you got? Is it more difficult to find a lump in the breast with an implant? No, it isn't, and a lot of people worry about this, Kemi. The implant is either behind the breast or behind the muscle. Either way, well, sorry, it's either in front or behind the muscle, the implant, but both. Wherever you put the implant, it's always behind the breast. There's no breast tissue behind the implant. So an implant is not going to hide a breast. I think a lot of people worry it's going to hide a breast cancer. There could be a cancer growing behind the implant they won't know about. So that is not going to happen. We use implants when we do breast cancer patients who have a mastectomy. you know, it's not uncommon to put an implant on the other side if they've always wanted to be bigger. When you're reconstructing a breast, you reconstruct the breast to a size that they would like. So if they have always wanted bigger breasts, you can reconstruct a bigger breast and then put an implant in the other side. So, you know, you wouldn't do that. You wouldn't put an implant in a patient who actually had a breast cancer if that was an issue. So there is no worry about finding breast cancers if you have a breast implants in. It's fine. And there was a study that said that you're going to find them easier because you've got a harder thing to push against with the implant. Also, I think patients got smaller breasts who've got implants, so maybe it is a bit easier to find lumps. But I don't think the implant makes it easier to find a breast lump. I think it's the same. It is the same. It doesn't make it more difficult to find a breast lump if you have an implant in. So there's no problem with looking for breast lumps if you've got implants in. It's no easier. It's more difficult. It's the same. But it's a good question. A lot of people worry about that. Is it normal for a male to have a tummy tuck? Do we carry out the procedure often? Yeah. I mean, is it normal? I mean, is it normal for a female to have a tummy tuck? I mean, what's normal? I mean, if you've got excess skin on your tummy, yeah. And the two things that do it to you are weight loss and having children. And clearly, males don't have the having children, not yet anyway, don't have the having children thing. So it's not as common as females, for sure, because obviously females have pregnancy and children, which stretches the tummy. So that's another reason for having a tummy tuck. So, you know, a major reason of having a tummy tuck is after pregnancy. But there are females who have not had a pregnancy who require a tummy tuck, just like there are males who might need a tummy tuck who have lost weight. So the mechanism is the same. The skin gets stretched, then the stretching force goes, whether it's stretched by putting on weight or whether it's stretched by having a baby. Either way, the effect is the same: excess skin on the abdomen. So it is perfectly reasonable for and perfectly normal for a male to have a tummy tuck. Yes, it is nowhere near as common as female. So do we carry out the procedure often? No, I wouldn't say often. 10 or maybe less than 10, like 5% or less. I don't know what it is. There's probably a figure somewhere, but it's a low. It's you know, less than 10%, maybe less than 5% of the tummy tucks, I would say, are male. The majority are female, simply because, as I say, females have pregnancy, which is a major cause for it. But yeah, it's absolutely perfectly reasonable for a man to have a tummy tuck. Perfectly reasonable. What we got here? Side torts. I'm interested in a breast reduction from 36 kk to a C or a D cup. Is that reduction too dramatic? Can it be done in one go? And how do you prevent keloid scarring in dark skin? Good. So yeah, I think it is a bit too dramatic. Side torts. I think double K to C or D probably isn't realistic. If you the bigger you are before, the bigger you are afterwards, and so you have to keep the nipple on a pedicle. Although double K, you might be looking at a free nipple graft where you take the nipple off and put it back on again, which gives you a little bit more flexibility in terms of the volume. But nevertheless, they will still be big. I'll tell you that now. And I don't think there'll be a C cup. There probably won't be a D cup. They'll probably be bigger than a D cup. Having said that, they will be significantly smaller than what they are. That's the thing that I can guarantee. And I'm sorry if that sounds a little bit vague, if you like, but you know, there isn't a specific thing that we have in theatre where we have cup sizes. So I did one yesterday, which was, I don't know what the patient was, but she's probably something like double K or whatever, and 2 kilos off each breast, and that was a free nipple graft, and that was a big reduction. But she's still big. You know, she's bigger than a C or D now. I don't know what she'd be, double DE maybe, but it's much more in keeping with her frame. What I normally say to people, I'm trying to get you back into normal shops, normal bra shops to get your bras. But you know, and sometimes I say, you know, you got to think what a C or D would look like on your frame. It might not look right. I'm trying to make it look right on your frame. I'm trying to make it reduced. I'm trying to make enough blood supply to the nipple, and those are the things I'm trying to do. I can't guarantee a final cup size, but I would say if you're double K, I would say that CD is probably unrealistic, and it will be bigger than CD, but it will be dramatically different to what it is now, and dramatically reduced. That you will be, you know, you won't think, oh God, they haven't done it done anything or be dramatic. How do you prevent keloid scarring and dark skin? There's nothing you can do to prevent keloid scarring, really. It's not a big problem for breast reduction. It can happen, don't get me wrong, particularly in the horizontal scar, which is fortunately not visible. You know, if you've got it in the scar around the areola and down, then it would be bad. Now, if you've got a history of keloid scarring, or if you've got a personal history or family history, then I would be worried. So I would, you know, there's nothing different that I would do. I mean, they do talk about using non-dissolvable sutures for keloid scarring, but there's so much suturing to do in a breast reduction. I probably would still use dissolvable sutures, and I would just say to you, look, we just have to keep an eye on it. If it does start to go keloid, there are things we can do to treat it. Silicone sheets that we were talking about earlier, steroid injections and things. But if there is a significant family history or personal history, if you've got other scars that are keloid, I would genuinely consider whether it would be worth taking on a breast reduction, because keloid scarring can be a big problem. So there's nothing specific we can do. If there was something specific we do it to everybody. So, you know, we do everything we can to give you the best scarring possible. But, you know, I have operated on quite a few people with dark skins, and there's no problems with keloid scarring, but there's no question that it is an increased risk in people with dark skin. So it is something to consider in the mix, particularly if you have a history of it. If you've got a history of it, I've got alarm bells. If you haven't got a history of it and you just got dark skin, I would, you know, yes, be aware of it, but I wouldn't kind of dwell on it too much, because there are certain areas. It's more like here and shoulder. You know, you've got much more risk of keloid scarring this sort of area. The breast is less of a risk, although still nevertheless a risk, nonetheless. I had 2 surgeries that haven't given me the result I wanted, and I have slight issue of pectus excavatum. I currently have moderate plus implants that meet in the middle, which isn't a nice look as they have slid into the dip. I have been given a possible option of polyurethane implants. In cases such as mine with the dip in the chest, would this provide a higher percent of having a more desired outcome? So I think this is probably the same person who asked a question on Instagram about this with a post that I posted saying, are they polyurethane implants? So yeah, I mean, this is what I was saying earlier about choosing your surgeon, because people worry about the implant that they get, but if the pocket's not made right, it is difficult. It is difficult. And this, what this patient's describing, is something called synmastia, which is where the pockets between the 2 breast implants join in the middle. So if you join the pockets between the middle, then you get a web between the breast, synmastia or uniboob, and it's a very difficult problem to correct, and it's a horrible thing for me to say, but it's a fact that it is a lot easier to avoid these problems in the first place. It is, you know, fixing problems, particularly with things like breast implants, is just really hard. And, you know, it's very hard to correct problems when the pocket is made too big. That's when you get into the realms of synthetic meshes and things like that. You know, for a primary case who's not had any surgery, I would never really use a mesh. But when you get into revision surgery, people get problems like this with problems with the pocket. It is really hard. Yes, polyurethane implants will help in answer to the question. Polyurethane implants do migrate a lot less, so they'd be a lot less likely to migrate into that pocket in the middle where the breast join. But you know, it is hard to correct the problem. Is the bottom line, and you know, it's very difficult once the pocket has been made too big. But yeah, I mean, I think if you ask me, I'd say polyurethane implants are probably your best bet. Now they have got a bit of a rep, because they got cancer in rats many years ago, and they've got an increased risk of ALCL, which is a cancer associated with implants. But in situations like this, in revisions, they're really good, and they're less likely to cause problems. But it is interesting that you're saying you've had 2 surgeries that haven't given you the results that I wanted. You know, these are kind of like alarm bells, really. Revision surgeries, you really want to minimize the amount of operations you have to your breast. So you've already had 2. I don't know how old you are, but, you know, usually you're thinking, you know, operations take, you know, 5 or 10 years. You might need to have your implants changed, hopefully longer than that. So you don't want to be having, you know, if it's been a few years and you've already had 2 and you're looking at a 3rd already, then that's more scar tissue every time, more capsular contraction, more scarring around the implants, operations become more difficult with scarring in the area. And yeah, so I don't know how bad your problem is. I guess it depends on how bad your problem is. I'd always say work with your surgeon. I understand people are anxious about that when the surgeon has caused the problem, but you know, all surgeons get problems, but you know, hopefully they'll be placed to fix them. That's why, again, you've got to make sure you choose your surgeon so that they're in a good place to help you out if you do get problems. And I guess looking at someone who's got a sort of breast reconstruction background might be helpful in these sorts of situations of difficult breast operations. You know, look for an appropriate qualified surgeon. Never accept a lift from strangers. How to choose the best plastic surgeon for your cosmetic breast surgery. Is that what it is? Yeah, I wrote the book on it, how to find a surgeon. So yeah, look for a good surgeon. But yeah, good luck with it. Difficult problem to correct, and I'm sorry to not be more helpful, but difficult problem to correct. Yes, polyurethane would be an idea because they certainly do migrate less. The other thing in cases of pectus excavatum, you could think about, it may be a bit late now, the horse might have bolted, but if someone has a significant chest wall deformity, either pectus excavatum or pectus carinatum. So excavatum is when there's a dip in the sternum, carinatum is when there's a bulge in the sternum. So if there's a rib cage deformity, you could think about getting referred to have potentially the chest wall deformity addressed prior to breast augmentation. That's something that we can discuss with patients if that's something they wanted to consider, because the other problem with chest wall deformities, that there can be an angle. So when you augment the breast, they can look a bit, they don't sit nicely. The asymmetry between your breasts can be accentuated with a chest wall deformity. As I say, if the chest is slightly tilted and you've got a small breast, it might not be very obvious. But if you make that breast bigger, it might look like it's going out that way. You might accentuate chest wall deformities with implants. So, you know, that's the other thing to consider. If these implants are sort of going too medial and then they, you know, you get them in a better position, they might look more asymmetrical if there is a chest wall deformity there. These are all things that kind of need to be addressed and looked at in terms of the shape of your chest and best way to fix it. But tricky problem, and I'm sorry you got it. And hopefully you can see how you go with that. So that was a good one, wasn't it? I think you'd all agree. Good engagement from the team. So thank you, team, for engaging with me. Very much appreciated. That I'm not on my own. I do appreciate the fact for that. Clearly, I'm a busy guy. I mean, I think we can all see that. So I've got things to do. So I'm going to go and do said things. But next week, I'll almost certainly be here at 7 o'clock. So if you've got any questions, call me, message me, or do whatever you've got to do. Email me, whatever, and I'll do my level best to answer them. But until then, have a lovely week. Hopefully we're going to get some good weather and get the Barbie out and just enjoy it while it lasts, because goodness knows it could start to... Oh, crikey. Sorry. Oh, God, sorry. Torrential rain at any minute. I should have stopped it when I should have stopped it. I'm still got the dodge. This is broken. My tripod's broken, so anyway, I shouldn't explain. Don't explain. This is what the pros do. When it all goes wrong on live TV, this is what the pros do. They just don't explain. Put it back. I'm not going to explain anything. Just put my tripod down, my broken tripod down. Pretend nothing happened. So, yeah. Thank you, Julia. You're on Facebook, so you didn't see the travesty that just happened on Instagram. Jackie, thank you for that. Thank you for being here, and you'll continue to support. And I better stop the stream before anything else disastrous happens. So I'll see you next week. I'll ask for a new tripod for Christmas. Sue, how are you? Brilliant. You all right? Yeah. All right then. See you soon. Bye.